Dear audience, may God bless everybody with peace and tranquility. On behalf of AETCM, warm welcome to everybody. Today we are going to discuss about a group of allergic disorders coming under the different headings: allergy, urticaria, angioedema and anaphylaxis. So they are together form a continuum of the allergy. So the body protects itself by the immune mechanisms, that's immune system. Sometimes when the immune system is inappropriately responding to some common harmless antigens, this is called the hypersensitivity reaction. The normal immune mechanism, which is protective to the body, abnormally and inappropriately behaving even to the harmless antigens. This is called the hypersensitivity reaction. This may manifest as minor or simple forms like atopic dermatitis or rhinitis. Sometimes it may manifest as very severe manifestations, life-threatening anaphylaxis or anaphylactoid reactions. What is allergy? Allergy is a type of hypersensitivity reaction, that is exaggerated, inappropriate immune response. And it is a continuum of many simple to complex and life-threatening problems. So what is allergic continuum? So before going to the allergic continuum, we will be just have a look at this allergic continuum picture. On the one end, we are having allergy, and the other extreme end is anaphylaxis. This allergy may be manifesting as simple things like allergic rhinitis or conjunctivitis or dermatitis, and the other extreme is the life-threatening anaphylaxis, which immediately not treated, the patient may lose the life. In between comes the urticaria and angioedema. All together they form the allergic continuum. So the triggers of allergy are called the allergens. Like antigens produce the antibody, allergens produce the allergic reaction. The most common things are food, some of the food materials, medications, insect stings, and allergen immunotherapies. The common manifestation of this group of allergic continuum is pruritus, flushing, rashes, urticaria, swelling of the lips, tongue, airway, angioedema, and abdominal manifestation like abdominal cramping, nausea, vomiting, and respiratory problems like shortness of breathing, wheezing, bronchospasm, stridor, airway compromise or hypotension, syncope and collapse. See, allergy is a type 1 immediate hypersensitivity reaction, IgE antibody mediated. And first thing we are taking up the urticaria. Urticaria is mast cell mediated, the histaminergic hypersensitivity reaction, IgE antibodies are produced. It may manifest itself as alone or it may be together with the angioedema manifest. So the triggers are certain types of food, drugs, physical changes, physical stimuli, hot or cold, temperature changes, everything. The manifestations: papule or wheals with central swelling surrounded by reflex erythema. Itching is a most important common feature, and then burning sensation. The sites of lesions are commonly in the extremities. So there are two types: acute and chronic. So it lasts for less than 6 weeks, it is acute form. When it is lasting for more than 6 weeks, it is chronic form. Then comes the angioedema. Again, it itself may manifest alone or along with the urticaria. The causes are almost the same: food, drugs, physical stimuli. There are different types of angioedema. One is non-allergic, non-histaminergic angioedema. See, this is bradykinin related. Here the manifestation is only angioedema. There is no accompanying urticaria. This is acute attack, the increased bradykinin level. So bradykinin causes the vasodilatation and increased vascular permeability. Clinical features: edema of the subcutaneous and or submucosal tissues, that is skin as well as the submucosal cells, face, eyelids, lips, tongue, extremities, pharynx, larynx and genitalia. So involvement of the upper airway, so always be compromising the airway, and there may be airway obstruction of various degrees, and we have to be very careful in the airway management. So again, angioedema is having 4 different subtypes. Hereditary angioedema, acquired C1 esterase inhibitor deficiency angioedema, ACE inhibitor induced angioedema, and idiopathic angioedema. So the diagnosis is only clinical. So most important thing is history of exposure to some allergens, and a positive history of the past history as well as the family history will be there in the case of the angioedema. And management, there are 2 different types. This, when the angioedema is accompanying with urticaria, the treatment will be little different. Without urticaria, so this is a non-histaminergic or bradykinin related angioedema. Acute attacks may not respond sometimes to epinephrine, antihistamines or steroids. But one exception is when there is an airway threatening angioedema. So no prior history of angioedema, epinephrine and antihistamines at anaphylactic doses. Remember, anaphylactic doses is the most important thing in the management of this sort. So airway management may be needed when you are thinking about going for an RSI. See, an awake intubation is much more safer than administration of the sedative, induction agents and paralytic agent. Always try to avoid the paralytic agent. We can go for an fibro-optic laryngoscopic methods. So the patient is awake. At that time, the safety of the patient is much more than paralyzing and submitting. Sometimes they may land up in difficult airway or difficult intubation. So they may be have to be resorted to the surgical airway. Keep surgical airway. We have to be prepared immediately for going for either tracheostomy or cricothyroidotomy or that. This is the management. Fresh frozen plasma. This is containing C1 inhibitor, so it may be transfused. Sometimes the fresh frozen plasma itself may exacerbate the angioedema. Please be careful. The another form is the angioedema with urticaria. So epinephrine is the treatment of choice in anaphylactic dosings if the symptoms are very severe and no cardiac risk factors are involved. And antihistamines, first line treatment if no criteria of anaphylaxis. Remember, if there is no criteria of anaphylaxis, antihistamines may be tried. H1 antihistamines and H2 oral antihistamines both can be administered, and oral corticosteroids also second line of treatment. This will be helping in the prevention of the future, this one. Okay. So there are another variety of angioedema, thrombolytic induced angioedema. When we are giving thrombolytic agents like recombinant tissue plasminogen, so this angioedema may manifest. This may also cause airway compromise. So whenever we are administering, we have to keep in mind about this risk. So suppose the patient is already on ACE inhibitor and you are administering the recombinant tissue plasminogen, the effect will be manifesting very severe, and we have to keep in mind. And the treatment part is containing of the antihistamines and corticosteroids. Epinephrine also sometimes most important treatment aspect. So disposition of the angioedema, certain patients need definite hospitalization. There persistent angioedema of sublingual area, tongue, soft palate, pharynx and larynx. We have to hospitalize the patient. Sometimes they may need ICU care also. So otherwise discharge after observation. So this can be done when there is extraoral facial lesions. Okay, we have to observe the patient till the complete resolution of the angioedema. So then coming to the anaphylaxis. So if it is not immediately recognized and not promptly treated, we may be losing the life of the patient. So anaphylaxis includes both anaphylaxis and anaphylactoid reactions. There was a different name and it's a different group for the later anaphylactoid reactions, but present day, so the anaphylaxis includes both anaphylaxis as well as anaphylactoid reactions. The clinical manifestations and treatment of both are identical. The only difference is anaphylaxis and immunological IgE mediated reaction, and anaphylactoid reaction is non-immunological, non-IgE mediated one. So anaphylaxis is a type 1 hypersensitivity reaction, previously sensitized individuals, sudden onset of life-threatening systemic reactions following exposure to an allergen. Risk factors for the anaphylaxis: pregnancy, history of atopy, acute infection, or even physical or psychological exertion may cause anaphylactic reactions. So, certain factors will be causing increased severity and mortality. One, anaphylaxis in the extremes of age, when the patients are already having cardiopulmonary comorbidities, the exacerbation or the severity will be very high and mortality rate is also very high. And one more this thing is, we have to institute the immediate treatment with epinephrine. Any delay in the administration of epinephrine also will cause increased severity and mortality. When the anaphylaxis occurs, when the person is in the upright posture, there will be severe symptoms and high mortality. And concurrent use of the antihypertensive agents, beta blockers, angiotensin converting enzyme systems also will increase the severity and mortality. Then etiological agents of anaphylaxis are food. One is peanut, milk, egg, shellfish, so many other things. And the onset of symptoms, it starts within 5 minutes to 30 minutes after ingestion. So the fatality may occur even within 30 minutes or even before that. Certain medications may also cause anaphylaxis. Antibiotics, certain antibiotics, NSAIDs, chemotherapeutic agents, dextron, etc. Insect stings, hymenoptera, venoms, fire ant stings, these are all the common things which may be causing anaphylaxis. And in day-to-day common use, natural rubber latex, especially when you are wearing the gloves, this may also manifest in anaphylactic reactions. Some hormones like insulin, methylprednisolone, and other things may also cause this anaphylaxis. Apart from that, local anesthetic drugs like benzocaine, procaine also may cause anaphylactic reactions. The radio contrast media is very common. See, the anaphylaxis may occur, but do not delay imaging in emergencies. And aeroallergen like pollen, dust spores, or pet dander may be causing the anaphylaxis. So, etiologic in continuing, so physical factors like exercise, cold, heat, and sunlight. Nobody can be imagining this will be causing anaphylaxis. But remember, exercise induced anaphylaxis, cold induced anaphylaxis, sunlight induced anaphylaxis may happen. In the case of exercise induced anaphylaxis, the advices you need to give is advise them not to exercise alone. So they should always do the exercise with somebody's presence. And if they are having the feeling of going for certain problem, immediately they have to stop the exercise. They should always keep EpiPen in their hand, in their pocket. And another type is idiopathic anaphylaxis, the cause unknown. And the clinical mediators and their effects in the anaphylaxis, there are so many number of chemicals are released, among which the abundance released are two different chemicals, histamine and tryptase. Histamine, immediate hypersensitivity and inflammation it is causing, and it causes increased vascular permeability and profound vasodilation. and smooth muscle spasm, increased mucus gland secretion, myocardial depression, etc. The histamine will be causing. And the manifestations of this one is generalized urticaria, angioedema, pruritus, syncope, and milder forms like conjunctivitis, coryza, rhinorrhea, bronchoria, bronchoconstriction, tachycardia, hypotension, abdominal pain, nausea, vomiting, diarrhea. And tryptase is adding fire to the fuel. Even adding the fuel to the fire. The effect is amplification of anaphylactic reactions and response. The clinical features of anaphylactic reaction, first thing is exposure to allergen. And almost all the organ systems are affected with varying severity and onset in rapid, in minutes to maximum within 2 hours. Severity, duration varies, clinical presentation also will be varying. When there is a life-threatening manifestation like airway compromise or breathing compromise or circulatory compromise or collapse, we have to be very alert in managing this and stabilize the patient with immediate resuscitation and ongoing treatment. Skin manifestation is common in 80 to 90% of the patients, and nasal congestion and sneezing also common. In the eye, itching and tearing. So angioedema, swelling and burning sensation in the affected area. These are all the common clinical manifestations. So coming to the respiratory symptoms caused by the anaphylaxis, cough, sense of tightness, dyspnea, throat tightness, stridor and audible wheeze. In CVS, hypertension or arrhythmia, CNS, syncope, seizures, GI systems, common in elderly because of food allergy. Abdominal pain, nausea, vomiting, tenesmus. So remember, the anaphylaxis causes a major life-threatening problem, hematological problem, that is fibrinolysis and disseminated intravascular coagulation or abnormal bleeding and bruising. So the bleeding may occur from the mucous membrane. Okay, genitourinary tract increases the uterine tone, vaginal bleeding, uterine smooth muscle contraction, bladder smooth muscle contraction, urinary incontinence. But in children, we may not able to anticipate hypotension and shock, but other manifestations will be there, and you have to be very carefully clinically evaluate the children. So the differential diagnosis of anaphylaxis is asthma exacerbation, myocardial infarction, pulmonary embolus or vasovagal syncope. So clinically diagnostic only primarily differential diagnosis and clinical diagnosis. Management, the most important thing, immediate recognition and immediate administration. First line agent is epinephrine. So epinephrine should be given intramuscular. Where to give it? At the lateral aspect of the thigh. That is distal lateral aspect of the thigh in the vastus lateralis muscle. So the doses for adult and pediatrics are different, and it needs to be repeated every 5 to 10 minutes if necessary. So there are ready-made EpiPen available either for the adult as well as for the juniors, JR. And most important next step in the management is removal of the triggering agent. For example, sting of an insect bite, and continuous monitoring of cardiorespiratory system, and management of the resuscitation of the airway, breathing, circulation, disability and exposure. So these patients may need RSI. So always go for a weak fibro-optic intubation and be prepared in case necessary to go for rescue or surgical airway. And oxygen administration, IV fluids. We need to give in the shortest time large volume of isotonic crystalloids. Example, normal saline. Say 1000 ml in 5 minutes, because profound vasodilation, we have to fill up the vascular compartment with IV fluids in the shortest duration. In the pediatric, IV fluid dosage is 20 to 30 ml per kilogram body weight. If you are in a pediatric age group, we are not getting an IV access, we can go for the IO access. Apart from that, H1 and H2 blockers, corticosteroids, And another thing is positioning. So always keep the patient immediately in supine position and elevate the lower extremities to promote the venous return to the heart. In the case of pregnant patient, nearing term, left lateral position is the most important. Positioning. Positioning is also important. Don't forget. So just to enumerate or sum up the anaphylaxis treatment medication, first line is epinephrine. Second line, this should not precede the administration of epinephrine. First line is always epinephrine, epinephrine, only epinephrine. That is second line is antihistamines, diphenhydramine, famotidine, and if there is a bronchospasm severe, then aerosol the beta agonist, and then albuterol IV and ipratropium. These are all the certain agents we have to administer. Third line is glucocorticosteroids. No benefit in the acute management. So methylprednisolone or prednisolone are administered as third line for prophylaxis as well. And then most important thing, keep in mind about refractory hypotension. The hypotension is persisting out of all the treatment modalities you are attempting to. In such patients may require continuous IV epinephrine infusion. Okay, there are given the dosage of adult and pediatric. Infusion, it should be continuing. Other adjunctive vasopressors are dopamine, norepinephrine, phenylephrine, etc. So the one more category of patients who are receiving the beta blockers. So it is very difficult to manage the hemodynamic instability. So patients may definitely require glucagon. The dosage is 1 to 5 milligram intravenous over 5 minutes, followed by 5 to 15 microgram per minute continuous infusion. And disposition of anaphylaxis, before disposing the patient, keep in mind about the another complication, biphasic reaction. What is biphasic reaction? This is a recurrence of the anaphylactic symptom after a gap of normalcy. This may occur within 8 hours. Sometimes it may be delayed even up to 72 hours. So don't be satisfied that the patient is all right with your treatment. So always remember biphasic reaction. So these patients always should be kept under observation for prolonged period and at least make sure that they are 1 hour asymptomatic. So certain patients need admission, protracted anaphylaxis, protracted hypotension, airway compromise, and those who receive more than 2 doses of epinephrine, they need to be admitted if necessary in ICU also. So before discharging the patient, educate the patient, even including the use of EpiPen. And medical identification devices, anaphylaxis bracelet or wallet. And allergist consultation and further follow-up is necessary. Then we come to the anaphylactoid reaction. This is an old terminology still in use. Remember, it is non-IgE or non-immunological reaction. Results in direct degranulation of the mast cells and basophils. Its clinical presentation and treatment are identical to that of the anaphylaxis. So, the anaphylactoid reaction occurs even at the first exposure of the allergen. So, example, NSAIDs, monoclonal antibodies, local anesthetic, chemotherapeutic agents. Some of this which will be causing this type of reaction. At the end, to sum up, anaphylaxis is a life-threatening systemic allergic or non-allergic reaction of acute onset, and it involves multi-organs which needs immediate recognition and prompt treatment. Yes, history of sudden urticarial rashes accompanied with respiratory difficulty, abdominal pain or hypotension strongly favors the diagnosis of anaphylaxis. So if it is anaphylaxis or you suspect anaphylaxis, the first line of management is epinephrine. And there is no absolute contraindication to use epinephrine in the setting of anaphylaxis. Remember, you need not worry about any contraindication. If the patient is thinking in anaphylaxis, the epinephrine, there is no absolute contraindication. Antihistamines and corticosteroids from the second and third line agents. They should never be preceding the administration of the epinephrine. So remember about the refractory hypotension, these patients need continuous IV epinephrine infusion or glucagon if they are on beta-adrenergic blockade drugs. See, these patients who need prolonged observation or admission, those who experience protracted anaphylaxis, hypotension, airway involvement or unknown trigger. Those who receive IV epinephrine or more than 2 doses or more than 1 dose of IM epinephrine. So these are all the patients who need admission somewhat. And non-histaminergic angioedema does not typically respond to epinephrine and antihistamines, though they should be considered at initial presentation. Initially, we may not be able to differentiate whether it is anaphylactoid or anaphylaxis, so no harm in go for the treatment for anaphylaxis, same drugs we can institute. There are certain newly approved, FDA approved drugs, so which are more useful in the hereditary angioedema, and the role of the fresh frozen plasma. So is having varying success in the hereditary angioedema, acquired C1 esterase inhibitor deficiency, and angiotensin converting enzyme ACE inhibitor induced angioedema. Thank you so much for your all, and we wish you to be calm, always be cool, and at the end the success and you can conquer anything. Okay, blessings from everybody.